Hello, this is Mrs. Lewicki, and I'm talking to you about the subject of disorders in hematology. Acquired hemolytic anemia is destruction and hemolysis of red blood cells. This can be due to physical trauma, such as massive tissue trauma, burns, dialysis, prostatic heart valves. What happens is the mechanics can beat up on the red blood cell and destroy it, cause hemolysis. Microangiopathic reasons, such as passing by large fibrin or platelet aggregation. Antibody reactions, such as through a blood transfusion reaction or through infectious agents. To continue with that, clinical manifestations are consistent with those of anemia. They can get tachycardic, short of breath, fatigue, pallor. Diagnosed through a CBC peripheral blood smear, which a peripheral blood smear is when they put some of the cells on a slide and look at it under a microscope. Treatment is supportive, corticosteroids, blood products, and splenectomy. Another bleeding disorder is thrombocytopenia. In thrombocytopenia, we're looking at platelets less than 150,000. Causes are immune thrombocytopenia purpura, which is an autoimmune disorder, or it can be acquired. In ITP, clinical manifestations, it can be platelets are covered by antibodies, and in ITP they function normally, but the spleen views them as invaders. So in ITP, the platelets only last 1 to 3 days rather than the normal 8 to 10 days. It can be chronic in women ages 20 to 40 with a gradual onset. Patient may have purpura, which are the dark red spots, which is bleeding into the subcutaneous tissue, or and they're usually pain-free, and they could have petechiae, which are the small flat pinpoint or reddish brown spots, which is rupture of small blood vessels. Their symptoms, they're generally asymptomatic, but they can get some superficial bleeding, such as epistaxis or nosebleed, or bleeding of their gums. I talked about the petechia and purpura, and the major thing I worry about with ITP is that they have internal bleeding and hemorrhage, so they can get that from any site. So I want to make sure that I'm closely monitoring their vital signs. They could get a GI bleed, hematuria, or a cerebral bleed. Diagnosed through a CBC, and I'm going to get low platelet counts on that. Treatment is corticosteroids. We reserve platelet transfusions for when they're less than 20,000, unless the patient is symptomatic. With platelet transfusion, you don't worry about ABO incompatibility. And patient may need a splenectomy, which 90% to 90% of those show improvement if they've had a splenectomy. Nursing care for this patient is definitely monitor for bleeding, no IM or sub-Q injections, bland or soft diet. We don't want to have anything that irritates the gut, leading to a GI bleed. We would also have a soft bristle toothbrush. Be aware of all medications. Some medications can cause a reduction in the platelet count. Watch the vital signs closely because the patient is at risk for bleeding, and so I need to see that. Then it may demonstrate in my vital signs first, and assess for signs and symptoms of increased ICP. Heparin-induced thrombocytopenia is another bleeding disorder. Heparin prevents conversion of prothrombin to thrombin and fibrinogen to fibrin. That happens in the clotting cascade. About 8 to 17% of patients who receive heparin develop heparin-induced thrombocytopenia. We refer to heparin-induced thrombocytopenia as white clot syndrome. What happens is the platelets are activated because of an immune problem, and they aggregate together, forming these white clots in the microvasculature. Now, we used to give heparin to lots of patients all the time. We would give it in their IV lines were all flushed with heparin. So we've changed a lot of that practice, but we still see the HIT, or heparin-induced thrombocytopenia, occurring. You get a fall in your platelet count, 30 to 50%. Your PTT time, it becomes shorter rather than longer, so the patient's receiving heparin. I expect for there to be a prolonged PTT time, and instead I'm getting a shortened time. Usually can occur 5 to 14 days after heparin is started, and what you're seeing is that the heparin is not being effective. Diagnosis is through CBC, and we're looking at low platelet counts, and there's a test, a lab test for HIT, and we're looking for that to be HIT positive. We would remove all heparin sources. Patient would receive no heparin, and that generally helps with the problem. If for some reason they still require anticoagulation because they have a valve replacement or DVT or pulmonary embolus, they would give a medication called argatroban to help with that. DIC, or disseminating intravascular coagulopathy, is a grave coagulopathy that accelerates clotting. It causes small blood vessel occlusion, organ necrosis, depletion of clotting factors and platelets, and activation of the fibrinolytic system. What you see is a lot of bleeding. It's caused by conditions such as shock, OB conditions, malignancies, tissue damages, septicemia, blood transfusion reactions. Tissue damage is such as things caused by burns, heat stroke, transplant rejections, etc. There's no well-defined sequence of events. Bleeding of unknown cause is usually your first sign. You see the signs and symptoms associated with hypovolemic shock. So you'll start to see pallor, petechia, purpura, oozing from puncture sites, any place that the patient has had a venipuncture or an IV start. You'll also see more frank bleeding, such as from GI bleeding, wound dressings, hematuria. Patient can get agitated, have an altered level of consciousness. Your patient will have a platelet count of less than 100,000, fibrinogen level of less than 150, prolonged PT level, prolonged PTT, and they'll also have D-dimers done and fibrin split products, and protein S and protein C. The treatment, this slide is not correct. We don't, it's not no heparin and it's not argatroban. We're going to treat the underlying cause. If there's septicemia, we're giving them antibiotics. We're trying to stabilize the patient so they will get volume. They may get blood products to replace lost blood products and to help encourage clotting. So they may get platelets, they may get FFP. And this patient may get heparin because what's happening is lots of micro clots are forming in the blood vessels. And so it uses up all of the clotting factors. And so they need to have a little bit of heparin to help get rid of those microclots. Another disorder is Hodgkin's disease, and Hodgkin's disease is 15% of all lymphomas. It's characterized by proliferation of abnormal giant multinucleated cells called Reed-Sternberg cells located in the lymph nodes. Most often 15 to 35 years of age, men get it twice as frequently as females. Cause is unknown. There are some possible contributing factors, such as infection with Epstein-Barr virus, genetic predisposition, exposure to occupational toxins. It's thought to arise in a single location, and about 90% of the time that's in the lymph nodes. It eventually infiltrates other organs, especially the lungs, spleen, and liver. Cervical lymph nodes are the first to be detected in 2/3 of the patients. Onset is insidious. They get nodes that are non-tender and movable, and enlargement of these lymph nodes in axillary area, cervical area, inguinal area. They have fatigue, weakness, chills, and tachycardia. They can also get fever, night sweats, and weight loss. Diagnosed peripheral blood smear, and the lymph node biopsy, which demonstrates these Reed-Sternberg cells. And they may also do a bone marrow to diagnose it. Treatment is aggressive chemotherapy, and they may have bone marrow and stem cell transplantation. Of interest is that in Hodgkin's disease, ingestions of even small amounts of alcohol can lead to pain at the site of the disease, and they're not really sure why that happens. Leukemia is another disorder, and it's a group of malignant disorders characterized by abnormal proliferation of white blood cell counts, and it can be acute or chronic. Symptoms include anemia, fever, weakness, fatigue, frequent infections, loss of appetite, and weight, easy bleeding or bruising, swollen lymph nodes, and enlarged liver and spleen. Diagnosed with via peripheral smear, bone marrow biopsy. They'll do a lumbar puncture, CAT scan. AML and ALL have chromosomal abnormalities, and CML demonstrates a Philadelphia chromosome. And the goal is to attain remission. And so they may do some type of chemotherapy or radiation depending on the cause or the type of leukemia. Acute lymphoblastic leukemia primarily affects children and young adults. Manifestations are what we talked about in the earlier slide, and treatment is chemotherapy, bone marrow transplant, stem cell transplant. Chronic lymphocytic leukemia is usually your older adult. It's an insidious onset and slow chronic course. Often requires no treatment, but they may have chemotherapy or a bone marrow transplant. Acute myeloid leukemia is usually older adults, but it can also affect through the lifespan. Strong association with toxins, genetic disorders, and treatment of other cancers. And treatment is chemotherapy and a stem cell transplant or a stem cell transplant. And chronic myeloid leukemia primarily affects adults. Early course is slow and stable, progressing to aggressive phase in 3 to 4 years. Treatment is interferon, chemotherapy, and stem cell transplant.